So I think to treat colorectal cancer today, one must do some molecular testing and molecular profiling to be able to make sure the patients get the best therapy and have the best outcome. And there are a couple of key issues that we need to deal with and identify the appropriate patients for different therapies today. So the first thing is microsatellite stability or instability, and that has to do with expression of mismatch repair enzymes. Most pathology departments can do immunohistochemical staining for the 4 mismatch repair enzymes very easily. And that should be done today on every primary colon cancer resection. For 2 reasons. First of all, if it's an early stage, stage 2, those patients probably don't need to get adjuvant chemotherapy. They have a very good prognosis. And if they have stage 4, we know now that these people will be candidates for immunotherapy with an anti-PD-1 or anti-PD-L1 drug. They all seem to work very well for patients who have MSI high. And MSI high means they have microsatellites, little pieces of DNA, which result from the fact that the mismatch repair enzymes aren't working correctly. So that's the first test that should be done on all colon cancer patients. For patients who have metastatic disease, we also want to understand their RAS status. So now we have KRAS and NRAS, at least 6 codons should be tested to see if they have a mutation or not. And the mutations will help determine if they are candidates for anti-EGF drugs. So today we have cetuximab and panitumumab that are both equally active and can be used for patients who are RAS wild type. But unless we know that, you can't really treat people appropriately. And then the third molecular abnormality that's important to know about is the BRAF V600E mutation. So that's a mutation in the RAF signaling molecule in the EGF pathway. Those patients are normally EGF or RAS wild type. Those patients are normally RAS wild type, but they will have this BRAF mutation. So that's 7% of all colon cancer, or about 15% of RAS wild type patients. If they have a mutation in BRAF, they can receive a drug to inhibit signaling by that drug, a BRAF inhibitor, which are already approved for melanoma. In colon cancer, they didn't work well by themselves, but we showed at this meeting in a SWOG study, SWOG 1406, that if you add that drug, you add the drug, a BRAF inhibitor, vemurafenib, to irinotecan and cetuximab, the progression rate was less than half. The hazard ratio for progression was 0.4. So patients, instead of progressing in 2 months, it was about 4.5 months with the addition of vemurafenib. So this is kind of validates the biology that had been explained already when we learned that the BRAF inhibitors didn't work by themselves. You need to block EGF signaling in addition to blocking BRAF in order to really get tumor responses. And that has now been validated clinically with this randomized phase 2 study from SWOG.